Hi there, welcome to our pharmacy revision series by CBH Education. Today we're going to be talking about benzodiazepines. So with benzodiazepines, we're going to talk about the common misconceptions of benzodiazepine, the mechanism of action, side effect, key drug interaction, counselling points, an example of how you would calculate a benzodiazepine by converting it from one benzodiazepine to the other, and then a case study in your OSCEs as well. So what you may find is the misconceptions of benzodiazepines. As pharmacists evolve in GP practice, you will see a great number of patients who are prescribed benzodiazepines long term. This can be historical, this can be mental health, this can be epilepsy. And one of the key things is that when benzodiazepines were originally discovered, or when they were made and brought into clinical trials and then obviously prescribed them to the market, they were the wonder drug. And that evidence has changed that, because some of the things that they found is benzodiazepines have withdrawal effects. They have patients have anxiety with them as well, and there's a whole host of things and other issues that come along with it. And the key thing is addiction as well. That's another thing. So when the patients are on the drug, they have it long term as well. So one of the things now is you'll find in the SPCs that they've been updated for short-term use only. Okay, let's explore what benzodiazepines are and how they work. So basically, they target the GABA receptor, which is a chloride channel. And basically, benzodiazepines enhance the binding of GABA to the GABA-A receptor. Side effects. There's quite a lot of side effects here. So some of the main ones you'll find is ataxia and confusion in the elderly. You'll also find dizziness, drowsiness, hypertension, and the mood can be altered as well. Drug interactions, so for example, with drugs that work in the CNS, for instance, they can have a CNS depressant effect. So absolutely key if you've got patients taking antidepressants, some patients taking other medications that can affect the CNS as well. And the monitoring is you've got to review the patient for side effects. Something that is key here, instead of putting it on the repeat prescription if you work in GP practice, you leave it on the acute, so it sets up that review process as well. Now, the MHRA has advised the risk of potential fatal respiratory depression. In terms of stop-start criteria, which you use in your medication review, you've got to make sure if prescribed for 4 weeks or longer, now this can be due to a whole host of reasons, that you are reviewing those patients. And obviously, if they're taking it long term, it is gradually withdrawn. Okay, so you haven't got that risk of withdrawal symptom. You don't stop the medication suddenly. Okay, you've got to review what dose they're on, come up with a strategy, and this is what we'll discuss in our later part of the presentation when we talk about managing cases and managing expectations. You've got patients which are prone to falls, so hospital admissions as well. That's absolutely key. And obviously we've talked about the withdrawal symptoms, and then obviously counselling on the CNS depressant effects at the point of issue of the medication, and if you're working in community pharmacy, when dispensing the medication as well to the patient. Okay, so this is a table showing the information about benzodiazepine and conversion. One of the key things that you've got here is you may be asked in your pre-registration exam to convert from one preparation to another. Okay, so this is a real life case study that one of the clinicians actually supported GPs with. So this is a patient, JF, who is 50 years of age. They've been on Diazepam 40 milligram for the last few years and want to withdraw from the medication. They've read the literature about long-term use of benzodiazepines. And one of the key things that's here is that they want to withdraw because it's no longer supporting them in terms of they're not finding it effective. So the patient JF just takes Diazepam. How do we withdraw the patient? So there are many ways to deal with this case, and one of the things is you've got to be competent in how you're going to handle it. So you've got Diazepam 40. So the colleague who dealt with this wrote to the mental health team, and they've said, look, patients on a high dose, convert them to Diazepam and wean them off very, very slowly. Now you can wean them off by 1 to 2 mg every week. Okay, so this patient opted to be weaned off with 2 milligram because they were motivated and they want to be withdrawn as quickly as they could, and in a safe, effective way as well. And you have to have an honest and frank conversation with the patient that there's no time limit on this. The progress can be slow. They will relapse. They will get the withdrawal symptoms. So how are you going to manage this? Now, would you just give a set of post-dated prescriptions and just let them get on with it and not review them? As a clinician, or even as a pharmacist prescriber, nurse prescriber, or even if you are in a prescribing capacity and you are managing patients, and even if you're an advanced clinical practitioner as well, or an advanced nurse practitioner, it's really making sure that that patient is reviewed regularly, because your guidances will say that the main care cause of concern has got to be your patient. You've got to put patient-centered care first. Okay, so how was this patient reduced? So they were reduced by 2 milligrams, and they were reviewed in a 3-week period. So, for example, you could be asked to calculate the number of diazepam tablets that you're going to prescribe with each strength. So this table will show best way to work out this calculation would be week 1, 20 milligram, 2 milligram for 7 days, that's 14 tablet. Week 2, 18 milligram, a split between 2 milligram and 10 milligram. Week 3, 16 milligram, a split between 10 milligram and 2 milligram. And then obviously you work out your respective quantities. So over a 3-week period, 28 10 milligram, 28 10 milligram tablets, and you have 49 2 milligram tablets. Okay, and post-dated prescriptions with that as well. Right, how do we then review the patient? Is really sitting down with them and having that consultation. So you talk about obviously side effects that they've experienced. You look at, are they having any problems as well? How motivated they are as well? Is there any cause of concern for relapse? Do they need to be maintained on a same dose for a specific period of time? Because believe me, a lot of these drugs, especially with the benzodiazepine, because they're that addictive, patients do have a real motivation when they're withdrawing. So this patient actually withdrew over a 4-month period. They relapsed a couple of times, but once they came off the medication, they didn't go onto an alternative benzodiazepine afterwards. They've remained off the benzodiazepines. They feel much better in themselves as well. Yes, the side effects are still there, your tiredness, but there was no withdrawal symptoms. And obviously, because they've weaned off of it now, they actually are more motivated to do a lot of the tasks at hand. So it's really key, and you do get that positive impact as well. Okay, so an example of another case study which one of our clinicians went through was patient JX is taking Zopiclone. They're 26, they have leukemia. So they're taking Zopiclone 15 mg, dexamethasone, ondansetron, cyclosporin, and morphine, and they want to withdraw from Zopiclone. What strategy do you have to put in place? So obviously you can convert to Diazepam. That's one thing you can do. You can even withdraw with the Zopiclone as well, because obviously this patient was very, very determined. They actually withdrew off the Zopiclone over a 2-month period, and when they were drawing over the Zopiclone, they wanted to go down with the Zopiclone strength. And what you have to do is you have to put a patient preference in there as well. It's looking in the patient and seeing, right, if you're sat in their shoes, what am I going to be doing? Okay, how am I going to be feeling? How am I going to withdraw? And from the clinician side, it's the safety, it's the evidence, and then obviously it's issuing those prescriptions and doing everything, tapering it very, very slowly and monitoring those side effects as well. So you discuss about the withdrawal symptoms, you discuss about the withdrawal strategy. So this patient, they went 15 milligram every other day for 2 weeks, and then they dropped to 7.5 every other day. And then they went from 3.7, then they went to 3.75 every other day, developed withdrawal effects, but they persisted. And what happened was they went then to 3.75 every 2 days, and then obviously every 4 days, and then slowly they went to once a week, and then they withdrew. So the key thing information here is strategy. So your strategy was the slow reduction. Your support was doing the reviews, the regular weekly reviews in this case, the consultations about how they're getting on, any side effects that they're experiencing as well. What do they want to bring up? Have they got any issues that they want to discuss about the regime as well? And being that pillar of support, and then managing expectations as well. You're not going to continue prescribing it afterwards. They're going to withdraw. Okay, what happens if they relapse? How are you going to manage that as well? That's what you've got to have in your patient plan, and obviously your pharmaceutical care plan as well if you're doing an OSCE. Okay, because benzodiazepines, you do have to look from the patient perspective, because they've been on it for such a long time. It's absolutely key that obviously things are managed, and they're managed in a slow, and everything is done in a tapered way as well. Okay, so from a medication review, you've got the stop-start strategy, as mentioned earlier. You've got a strategy to reduce with the patient. Elderly patients, now if you're prescribing it new no longer than 4 weeks, what is the indication? So if you're looking to withdraw with epilepsy, if the patient wants to withdraw and they have been seizure free for so many years, you need to consult with a specialist. And again, with the mental health team, you need to consult with a specialist as well, because the thing is, patients may be prescribed 2 benzodiazepines, and what you can't do is, if they're on it regularly, you can't just suddenly stop the medication. You have to have that withdrawal plan in place. Sometimes if they're on a PRN medication, if they're on a PRR, if they're on a when required medication, and they're not using it often, they're only using it maybe once every couple of months, you can put a strategy in there for them as well, and look at alternatives as well. So, for example, a lot of patients in the care home setting may be prescribed Zopiclone, and sometimes are switched over to melatonin for 13 weeks, just to see how they are. And that's done obviously in kind of consolidation with the clinician, the mental health team, and which other party or expert is involved in their care as well. Okay, so example of pre-reg exam questions. So patient GS has been prescribed a benzodiazepine for epilepsy. Which medication is the indication for this? That would be diazepam. Patient AF has anxiety and has been prescribed a short course of a benzodiazepine, which has a recommendation to be no longer prescribed than 4 weeks. That would be lorazepam. And then patient SD has been prescribed a benzodiazepine for short-term insomnia. That would obviously be your Zopiclone. So one of the key messages here about benzodiazepines is obviously the side effect profile, the withdrawal. So in your OSCEs, your clinical practice, what issues are you going to face in there and how are you going to overcome them? Okay, and really liaising and engaging with the patient as well, and obviously adopting a strategy of safe, effective prescribing as well. Thank you very much for listening to this presentation by CBH Education on benzodiazepines. For more presentations on pharmacy revision, OTC revision, OTC condition, calculations, and other areas with pharmacy, please follow us on our Facebook, Instagram, and YouTube channels. Thank you.